Okay, thank you. Well, that I think elides neatly into the next paper, which is Bruce's report on progress with the urgent and emergency care review. Bruce, over to you.
Thank you very much, Chair. Perhaps I could just start by reminding people of why we're reporting on progress. A&Es have, in many senses, become the victims of their own success. They're a very powerful and trusted brand within our NHS. As Barbara says, the number of attendances has gone up slightly, but the real thing that's put our A&Es under pressure is an increasingly elderly population, which has resulted in an increased admission rate from A&E of 30% over the last decade, particularly in winter. And that means that people working in A&E and the associated services feel that they're in a bit of a pressure cooker. And as a result of that, we were asked to conduct a review in January last year. And we've done that review. We've tried to build that review and its deliberations in public. So we've collected evidence. We've had that evidence on display on NHS Choices, which gets up to 1.6 million unique visitors a day. That evidence has been modified according to what people say. The evidence has been reviewed by people who live and breathe urgent and emergency care services in conjunction with the public and patient groups. So we published a report in November last year. And as a course of that, I could just bring your attention to some observations that we've made. The first comes back to what I've said about A&E being a victim of its own success. Most people are seen within 50 minutes. That's the national average for being seen in an A&E. And most people, 95% of them, are done and dusted. That means they're either discharged or getting the right kind of treatment, or they're admitted to hospital within 4 hours. We also know that about 50% of patients who are dealt with through the 999 call system could be dealt with at the scene. We know that about 40% of people who attend A&E leave without any treatment, and in many cases that may be legitimate. We know that we have about 1 million avoidable admissions a year, and we know that medical science has changed dramatically since A&Es were introduced in district general hospitals. And as a consequence of the changes in medical science, which means that some conditions are better treated in centres of specialist expertise with more expensive kit, the end result is that over the passage of the last 2 or 3 decades, it's become absolutely clear that not all A&Es are the same. They have different types of services, different levels of services, and different support services. So we have come up, I think, with essentially 2 principles as a result of this review. The one is that for people with non-life-threatening conditions, we need to provide better out-of-hospital services than we provide at the moment, and in particular we need to provide those closer to people's homes, and in some cases in their homes, than we do at the moment. But secondly, for people with significant life-threatening conditions, we need to get them to the right place where they can get the best possible treatment through the best possible expertise as quickly as possible. So we need to try and address the broader issues. We think we need to do 5 things. The first is we need to provide better support for people to self-care. There's good evidence, particularly in long-term conditions, that the best people to look after themselves are those people who have the condition themselves. Diabetes would be a really good example of that. Secondly, we need to put systems in place that make it easy for people to get access to the right information and to direct them to the right services the first time. And that leads us into the territory of beefing up 111. We've learned a couple of things from feedback. We've learned that patients would like to have greater contact with clinicians, whether those be mental health nurses, doctors, nurses, pharmacists, dentists, or others, and that they would like to have the opportunity for us not only to direct them to the right place, but in some cases make appointments for them. The third thing that we need to do is we do need to ensure that there are more responsive services out of hospital closer to people's home. So we need to standardize the array of services that are out there that have been built up year after year, and attract a whole bunch of different names: urgent care centres, walk-in centres, GP-led centres. We need to standardize those. We need to be clear with the public about what that offer is, and we would like to see those standardized as urgent care centres. We need to improve access for patients with conditions that concern them to primary care, mental health services, and to community services. We need to increase the amount that people really use pharmacists. We know that the Royal Pharmaceutical Society are very keen to do that. There's been quite a bit in the media recently about how people could use pharmacists more. And actually, we have 400 million visits to pharmacists a year, and they're highly trained people to whom we could give more responsibility and in whom we could ensure that they give a more holistic offering, if you like, to the public. Another group of people who we're keen to promote are paramedics. There's an irony in a way that paramedics are very highly trained people who you trust, perhaps at some really difficult times in your life: road traffic accidents, heart attacks, strokes, so on and so forth. But much of the time, we use them for transporting people. And actually, we know that if we, with a little bit of extra training, we could ensure that they treated people in their homes. We could, there are other activities they can do. They could suture people at scenes. They could put in urinary catheters rather than bringing people into hospital where they wait for somebody else to do it. There are a number of things that paramedics would be perfectly competent to do if we ensured that they had the appropriate training and gave them the permission to do that. The fourth area that we need to address is we need to understand, both geographically and clinically, which units in the country can treat the most serious conditions. Now, this has led to a debate about a kind of two-tier service, and this is an absolutely false debate, because there are already specialist centres for treating heart attacks, there are already specialist centres for treating strokes, and there are already major trauma centres. And there has been a debate about whether that dilutes what is available locally. This is less than 5% of activity seen by a normal A&E, on the one hand. And secondly, there's been a debate that we'll subject patients to unnecessary risk if we add in the transport time. Well, that has clearly been disproven in both heart attacks and strokes. And interestingly, one of the other areas where there was a big debate was around trauma. And we now have 26 trauma centres in the country, so that patients bypass A&Es, which previously only treated one major trauma case every couple of weeks, to go to major trauma centres. And in the first year of doing that, we've seen a 20%, that's a 1 in 5, a 20% increase in survival for patients with serious trauma. So we need to learn from this and bring it to the benefit of the whole of the NHS and to everybody who needs our services. And then the fifth thing that we need to do is we need to acknowledge that we have portals of entry into our urgent care system which offer different levels of service. We have urgent care centres or similar. We have different types of accident and emergency centres, and we have very specialist centres. We need to network all of those together to bring the best possible care to everybody so that they're safe at whatever point they encounter the system. So we think that we need to think about how those networks are led, and we think it's probably through the major emergency centres by the provision of standardized clinical protocols, the sharing of training, expertise, rotation of staff who are training, by ensuring that we have good information transfer around those networks and between the units, by ensuring that we have standardized patient transfer protocols to get patients to the right place, because when somebody comes into, let's say, an urgent care centre with tummy ache, they may not know whether it's simply constipation, whether it's an abdominal aortic aneurysm, whether it's emerging cancer or otherwise. They don't know how serious it is, and why should they? That's why they've come in. It's our job to make sure that irrespective of what that diagnosis is, we get them to the right place. And of course, one of the roles of the networks would be to provide governance, a standardized governance through all of those so that we can ensure high quality care, standardized care, and identify where there are variations. So this is not a minor undertaking. It is a major undertaking, and there's going to be no kind of simple single solution. And there will be misunderstandings, I'm sure, in the route that we take to get there. But I would say the report was very well received professionally. Not everybody agrees with everything, but I think most people agree with the principles. I've been really impressed and very pleasantly surprised, if you like, at the very high quality of reporting, understanding, and dissection of this in all quarters of the media. It was absolutely superb, and it's exactly what we need when we have this kind of debate, because the NHS belongs to everybody. Now, the urgent and emergency care system consists of a number of different parts. It consists of 111, it consists of ambulance services, it consists of accident and emergency services, it consists of the services that sit in the hospital to support the A&E, and it consists of more local services. And all of those are commissioned by CCGs on behalf of the public. So we've asked CCGs, as part of their 2-year operational plans and 5-year strategic plans, in our planning guidance this year, to consider how they can start to implement the principles of this review as they think about how they design their services over the coming years. This review has been led by very effectively by Professor Keith Willett, who's lived and breathed this kind of stuff throughout his career. He's a professor of trauma and orthopedics in Oxford. And he's established a delivery group, and the members of that delivery group are outlined in the annex to this paper, but they're pretty broad-ranging, from NHS England, Monitor, the Trust Development Authority, Health Education Authority, the King's Fund, CCGs, and so forth. And they will be undertaking 8 areas of work. The first is to look at the payment systems, because different parts of the system which I've just outlined are paid in different ways. Some are paid through tariffs, some through block contracts, and so forth. And we need a consistency of payment in order that we can join these up in the most effective way. The second thing is that we're looking at primary care and community care access for patients so that they can get quicker access locally, closer to home to things. We're looking at how we can improve the 111 service. We're looking at how we can provide much better data and information sharing and care planning for people with urgent care needs. We're looking at how we can beef up the role of community pharmacy. We're looking at how we can understand which units we should designate as major emergency centres, and which units should lead, if you like, the quality assurance and control of the networks. And we're looking at how we can improve the role of paramedics and the ambulance service for providing care closer to home. And then finally, there is a work stream on workforce. So that work is now kicked off. I'm hoping that by the middle of the calendar year, we'll be able to come back with an update on where we are, Chairman. Thank you.
Well, thank you very much, Bruce, for that outline. Let me invite any questions to Bruce. Victor.
This powerful stuff, really, really strong and clearly well received. I just wanted to raise a couple of things. I know that mental health is mentioned in the paper, and throughout this, it's great to hear that the parity of esteem has been raised by a number of board members. But in relation to your presentation, you know, in London, if you have a heart attack, you get an ambulance 8 minutes, right? if you have a mental health crisis, which could just be as dangerous, and it's just as likely that you actually either may not get an ambulance or you'll get a police person, and the crisis response, the specialist equivalent for a crisis mental health situation might be a 136 suite, which is variable throughout the country, even in London. So I kind of wonder whether you might want to say more about mental health in this context, because when everybody thinks about A&E, and they think about physical health. They think about all the things that you've talked about, and we've done some fantastic work in that area. Where we are far behind, a long way behind, in this is in mental health. And in my view, you can't have parity of esteem unless you have parity of crisis response and A&E, and particularly the issue of transport, which you touched upon quite rightly in relation to ambulance service. There are key challenges in relation to mental health and transport to safety, which have actually resulted in some pretty horrific situations. So I just wonder whether you might want to say a bit more about that and how we're managing it.
We're working through some of this, Victor, but I would say one of the measures of a civilized society is how well it deals with its most vulnerable citizens. So we're going to stress test this, looking particularly at the extremes of age, looking particularly at mental health, and looking particularly at how we respond to people with crises of long-term conditions. So there will be a set of work streams designed to do that. But I would also say that we've seen some changes, if you like, in the demographics of people that ambulances, for example, are having to deal with. We're seeing an increasing number, as you've already alluded to, people with mental health. That becomes confused with an increasing number of people who take alcohol, and confused with an increasing number of people who take drugs. And different ambulance services are using different solutions for dealing with that, both in terms of the sort of people that they bring to answer the call, and how they get those people there. So, for example, the West Midlands Ambulance Services has some cars which have got 3 people in. They've got someone from the police, a paramedic, and someone trained in mental health. So there will be different solutions, and it would be foolish of me at this point to predict what they might be, because we're going to be working with experts and we're going to be stress testing this in the face of changing demographic demands. And of course, the bit that you alluded to, which is important and which some work is already going on, is how we deal with people in custody, which is
Thank you for a really, really good exposition on what is just a fantastic piece of work. My question is almost the flip side of Victor's question. That there's an inevitable move when one's streamlining and setting up networks to focus on the largest agglomeration of people in urban situations. And really, I'm thinking about how one tests everything here to ensure that it works appropriately for the hard-to-reach rural situations. Whether it's down to, I don't know, perhaps locating defibrillators and giving training to people in rural situations so that they can deal with some of those sorts of emergency occurrences. I don't know, but we need to ask ourselves the question that, it's the same question that we would ask in retail, whether we're dealing with the people at the last mile.
And that's a really good question. So it's one of the issues that we're grappling with. In many senses, some of this is relatively easy to implement in big metropolitan areas. And there's a risk, in a way, that you forget people out in rural or remote areas. Now, we've taken that pretty seriously. We think that they will need different access, different ways of assessing the seriousness of illness, and different ways of getting to diagnostics quickly. We believe that there's much greater use of technology that can be used to ensure that somebody who presents to a remote A&E gets immediate access gets immediate access, if you like, to the best advice through much quicker access via a network into one of the major centres. I mean, the kind of models for this already exist. So, for example, for many years, people who have had head injuries, it's been possible for experts in neurosurgical centres to be able simply to read X-rays or CT scans down the line. So we're looking at all of the opportunities that sort of technology and innovation will offer. So we're working, I think, in a different environment with much greater opportunity than might have existed at the time that A&Es were already initially established.
Thank you, Bruce, for that very powerful report. I did have occasion last night to dial 999 and to call for an ambulance for the assistance of a colleague who had had a very nasty fall, tripped over in the street, right in the middle of London, right in Oxford Circus. Two things really struck me. The first was how many passers-by came to his assistance, just straight away. He broke his nose, blood streaming everywhere. And people just stopped whatever they were doing and came and helped. And secondly, the professionalism of the ambulance crew when they arrived. So we sat in the back of the ambulance for some time while they assessed him, sorted things out, and eventually did take him off to A&E for X-rays. But I don't make a habit of being a mystery shopper of the NHS, but I just thought it was that the sheer professionalism, the capacity to do anything, and the calmness of approach and the promptness of response were all very impressive. So thank you very much, Bruce, for the report, and we look forward to further updates as the
just to point
review
out, this is
progresses.
one of the 6 characteristics that we described,
Yes.
so it's part of the strategy.
Right, well, thank you very much. I have no other business except to report that the date of the next board meeting is the 6th of March, and we will be meeting in Leeds on that occasion. So thank you all very much. The meeting is adjourned. We will, after lunch, resume in private meeting for some confidential business of the board. Thank you all very much.
Well done.
Meeting is closed.